Welcome to our online training on appointment systems, converting to open access scheduling. My name is Patricia Blackburn and I'm a Vice President at CARDIA.
And I'm Johanna Rosenthal. I'll be joining Pat as a co-facilitator on this course. On behalf of the California Primary Care Association and CARDIA, we are pleased that you have selected this module to support your professional development.
CARDIA is a nonprofit, mission-driven organization with a principled team of committed and passionate staff. We have dedicated our careers to helping health and human service providers offer their best to their patients.
You see here on this slide the official mission of the organization. You may be aware that CPCA is offering this training as a part of their Patient-Centered Health Home Recognition Program. This initiative is for its member clinics to support their efforts to achieve Level 3 standards of National Committee for Quality Assurance Recognition. CPCA has made a commitment to support every member community health center to become a patient-centered health home. For more information, go to CPCA's website listed here.
There are 4 objectives that will give you a sense of what we're going to cover in this module. These are the things we hope you'll be able to do as a result of taking this course. First, you will be able to identify which National Committee on Quality Assurance Patient-Centered Health Home standards this module will support. We'll quickly list all the major standards and then focus on those aspects related to open access. We know that scheduling methodologies and approaches were covered in great detail in the module on capacity and demand, but we wanted to still provide a brief reminder summary in this module so you can think about them in the context of our discussion on open access. We assume not every agency will be able to completely convert to an open access approach, so we want to give you some other options to consider, some of which you may have used in the past or may be using right now. Our last 2 objectives relate specifically to the open access systems. We'll discuss the advantages of open access scheduling, so by the end of the session you'll be able to describe to others what the advantages are of this approach. Finally, our goal is that by the end of the course you'll be able to describe key strategies to converting to an open access system. So let's begin by addressing our first objective, the NCQA Standards for PCHH.
The Patient-Centered Health Home Program has 6 standards that align with the core components of primary care. Within each standard, there are multiple elements and factors that need to be met and are described in NCQA documents. You may or may not be familiar with these standards, so I'll just quickly run through them. The first standard is enhanced access and continuity, which means the practice or the site provides access to culturally and linguistically appropriate routine care and urgent team-based care that meets the needs of patients and families. The second standard is identify and manage patient populations. This standard relates to the site systematically recording patient information and using that information for population management to support patient care.
The third standard is plan and manage care. This means that the site systematically identifies individual patients and plans, manages and coordinates their care based on their condition and needs and on evidence-based guidelines. The fourth standard is provide self-care support and community resources. This means that the site acts to improve patients' ability to manage their health by providing a self-care plan, tools, educational resources, and ongoing support.
The fifth standard is to track and coordinate care. The site systematically tracks, tests, and coordinates care across specialty care, facility-based care, and community organizations. And lastly, the sixth standard, measure and improve performance. The site uses performance data to identify opportunities for improvement and acts to improve clinical quality, efficiency, and patient experiences.
You've probably figured out that it's the first PCHH standard where open access is discussed, since the overarching goal of that standard is access to routine and urgent team-based care that meets the needs of both the patients and their families.
Besides the standards, there are 6 must-pass elements that are required for sites at all recognition levels because they are considered the building blocks of the patient-centered health home. Sites must receive a score of 50% or higher on must-pass elements. These 6 must-pass elements appear under various standards, but one is under standard number 1 on enhanced access and continuity. The must-pass element under standard 1 requires that patients have access during office hours. The factors that make up the must-pass element include one critical factor that must be met. This critical factor is providing same-day appointments, also called open access, advanced access, or same-day scheduling. Other factors covered under this element are advice by phone during office hours, advice by secure electronic messages, and documenting the advice in the medical records.
Why is increasing access so important? You may feel like your site or clinic is doing just fine, and perhaps it is, but here are some things to think about. Are your patients satisfied with how many days from the day they call they can get an appointment? For example, if a patient calls today for a routine checkup or well baby check, what's the earliest appointment they can get? Are patients satisfied with the length of time they spend in your office or clinic? No complaints doesn't necessarily equal satisfaction, but rather a resigned acceptance of the system that they are stuck in. Do you receive a lot of last-minute cancellations from patients who scheduled their appointment a long time ago? Do you and your staff work late to accommodate the double-booked patients that were squeezed into the schedule? Are there services you would like to offer but you don't feel that there's time or resources? Could your show rate improve? Do you know what your show rate or no-show rate is? Do you ever have wasted or unfilled appointment slots? Your answers to these questions may prompt you to think about how your appointment system could be improved.
Here are some of the benefits of a well-designed appointment system. A good system can have an impact on healthcare provider productivity, which means what? It could be the number of patients each provider sees in an hour, or in a day, or in a year. You can look at productivity at the clinic level or by individual provider. How your patients are scheduled is going to have a big influence on how many patients your providers can serve.
Well-designed appointment systems can also impact patient cycle time. Anyone who has conducted any type of patient flow study knows that cycle time refers to the length of time your patient is under your roof, so from the moment they arrive to the moment they check out or leave. If the appointment system matches staff availability, patient waits to see various staff should be reduced, and consequently total cycle time should be decreased.
Another potential positive impact is clinic flow. Here we're referring to the bottleneck spots in the clinic, the providers waiting for medical assistants to finish with the patient, or medical assistants waiting for providers. Clinic flow focuses on how efficiently patients move through your clinic. An appointment system that matches staff availability can do wonders for the flow of patients.
Patient wait time for an appointment can also be impacted by a well-designed system. This issue speaks to our question about how long it takes a patient to get an appointment at your site. Depending on your system, it could be the same day or the next day, next week, or several weeks.
3 final areas that can be impacted by a well-designed appointment system include potentially higher reimbursement. With a good system, you may have higher productivity, seeing more patients than before, which would ideally increase income. Another benefit relates to continuity of care. When patients see their own primary care physician more often, the provider is more familiar with the patient, so routine care is quicker. Patients are more comfortable opening up, and additional services can be offered for which you can bill. And lastly, one of the most common complaints about a site has to do with wait times. If your appointment system can decrease waiting time, your patients are going to be much happier and more satisfied. As discussed in the module on capacity and demand, there are some very important steps that one must consider when designing an appointment system that maximizes patient access and staff productivity. Pat, can you review these for us?
Sure. One of the steps is to developing a patient visit and unique patient program goals that meet budget requirements for sustainable programs and are informed by capacity and demand. Assessing clinic capacity and demand is another step, which includes the number of clinicians and the number of exam rooms. Selecting a schedule methodology or an approach is another step. Selecting an appointment system model is an additional step. And finally, incorporating scheduling principles and best practices that promote clinic efficiency. In this module, we're going to focus on 3 of the steps, which are the scheduling methodology or approach, so in other words, length of appointment slots, blocks of time, double booking, steady streams of patients, the appointment system model, which include traditional versus carve-out versus open access, and then best practices, what strategies work well to promote efficiency. There are a menu of choices to consider when designing your appointment system. How long is each appointment slot, and should they be the same length or different lengths? Are there any advantages to groups of patients arriving first thing in the morning and at the same time, which is called a block system? Or do you want them steadily scheduled throughout the morning, the stream system? Or what about a combination, where patients are gradually scheduled up until a certain time, but you also double book some slots, which is a wave system?
What do you do in your clinic? Do you know what considerations management had in making this decision? Think about the possible pros and cons of your current system. If you're watching this module with a coworker, consider hitting pause for a minute and discussing the pros and cons of the different elements that make up your appointment system. We recommend that you refer back to the capacity and demand module for a detailed discussion of the pros and cons of the various approaches and methodologies.
The capacity and demand module also talked about the different appointment system models, which are the traditional model, the carve-out model, and the open access model, also known as same day or next day or advanced access. These models include the different methodologies we've just discussed.
The motto for the traditional model is to do last month's work today. This is because there is typically a backlog of work to be done, but it also refers to the patients who wanted to get in a month ago and are finally getting in today. Each day, the provider arrives to a full schedule. The appointment schedule has a variety of appointment types, so different lengths depending on the reason for the visit, and patients have been scheduled 2 weeks to 2 months in advance. Urgent visits are squeezed in. Clinic tends to run late or behind schedule, and lunches are sometimes skipped. There are high no-show rates because patients have been scheduled so far in advance. Full schedules lead to increased urgent care clinic visits for those who really need services and couldn't make it onto the schedule soon enough. With this model having some obvious weaknesses, clinics started moving towards what's called a carve-out model.
The carve-out model is an attempt to improve on some of the flaws of the traditional model and is sometimes described as a first-generation open access. Its motto is, do some of today's work today. With the carve-out approach, appointments are made in advance, and many appointments are carved out for urgent or specific types of visits. Triage staff play a major role in determining who gets scheduled when. It's important to estimate the number of slots that need to be kept available for urgent or same-day appointments. It's good and bad news when it comes to access. Patients can get same-day access, but only if they meet the clinic's criteria, or the clinic is willing to squeeze patients in. Patients who have no urgent needs get bumped into the future, so work is delayed. Also, slots may end up unfilled, especially if you don't end up accurately predicting demand or if the right slot is not available for the patient's need. Appointment staff tend to tell patients to call back on the day they want to be seen because they can then release some of the slots they've been holding for same-day appointments. But this can impact the phone system when you have patients calling back twice as many times as they should. Additionally, staff are tempted to steal future reserved urgent slots because no other time meets the patient's need. Both of these practices interfere with attempts to accurately predict true same-day demand and create future scheduling problems. It's quite easy to end up returning to a traditional model with a saturated schedule. So finally we come to open access, also referred to as same-day, next day, or advanced access. Take a moment to think about what you already know or have heard about open access. Perhaps you don't know anything about it, or you've heard it's challenging, maybe initially frustrating, or a lot of work, but ultimately worth it.
Open access has the motto, do all of today's work today. To fully embrace this model really requires a paradigm shift.
Though initially challenging, open access scheduling has been found to lead to increased efficiency and productivity, the ability to increase capacity without expending significant resources, and greater patient satisfaction, among other benefits. So regardless of whether this was an NCQA critical factor, there are some very good reasons to work towards adopting this kind of scheduling system. Some of the characteristics of the open access model are that there is no distinction between routine and urgent appointments, so you don't have to be really sick to be seen the same day. And because patients can be seen on the day they call, they ultimately have greater access. Instead of phone staff asking the reason for your appointment, they ask who is your provider, because the reason doesn't influence the scheduling.
Other advantages of the open access model are that providers see their own patients. As we mentioned earlier, because there is this increased effort to make sure patients see the same provider, providers have a more established relationship with their patient, more time to provide extra services for them, for which the provider can bill, and patients are more satisfied. Lastly, the show rate tends to be better because appointments haven't been scheduled 2 weeks or 3 months in advance. In an article on open access by ECG Management Consultants, this point was illustrated by showing this graph of the impact of scheduling way in advance and how it influences show rates. As you can see, patients that were scheduled within 1 week were much more likely to show up for their appointment than those who were scheduled within 2 to over 10 weeks in advance.
In addition to the no-show rate being lower because fewer patients are forgetting about their appointment, there tend to be fewer cancellations since there is less time for a scheduling conflict to surface. Patients are also more certain about their ability to keep their appointment at the time that they schedule it. With traditional models, where you typically have long waits to get an appointment, patient symptoms may eventually subside, or symptoms can get worse, leading the patient to seek help elsewhere. You are therefore more likely to be left with a schedule that has last-minute unfilled slots at the end of the day.
With open access, you don't have to hold appointment slots open to meet the same-day needs because you've gained capacity that you didn't have before by doing today's work today. At least 50% of appointment slots are open at the beginning of the day. The slots that are booked prior to the same day consist of patients who did not want to be seen the day they called and requested another day, even though the same day was offered, and patients who were scheduled for follow-up visits by their provider. Both of these are considered good backlog.
Because the majority of the appointments are made the day before or on the same day, staff do not have to spend nearly as much time making reminder or confirmation calls. Therefore, their time can be spent doing some tasks that contribute more directly to patient care. Call volume can increase if you end up being able to take on more patients, but you shouldn't need to increase your phone staff. The time spent on the phone with each patient is shorter since the schedule is simpler with single appointment links and less triaging. There is also less time spent rescheduling patients.
There are fewer emergency department or urgent care visits because patients' needs are met more immediately and conditions are not left untreated. Therefore, the cost of care is less than it potentially would have been had they had a long wait. Having appointment slots that are all the same length is a characteristic of the open access model. Single-length slots have been found to simplify the appointment-making process. The receptionist spends less time doing phone triage to determine what kind of slot to give the patient, thereby speeding up that process. Some visits will be shorter, while others are longer, but they tend to balance each other out. A disadvantage someone might think of is that one might be concerned about the patients who need more time completely throwing off the schedule. But as I said before, ideally, the visits that take less than the allotted time balance out the schedule.
However, let's talk about these longer visits since they can be viewed as a huge barrier to using this kind of appointment schedule. Longer visits are typically caused by patients who don't communicate well and have multiple issues, or when patients are not scheduled to see their primary care physician. It takes more time for the new provider to become familiar with this patient, and there's also less continuity of care, which is another issue. Other reasons for long visits could be having incomplete patient records, like a lab result that hasn't been filed, or patient records that haven't been transferred, or a room that's not been adequately stocked or prepared.
Minimizing long visits does not mean that you're denying your patients the care they need, but it does mean that you're being more efficient and allowing them to move on with their day. They really do have other places they'd prefer to be. Believe it or not, allowing patients to talk without being interrupted for 2 minutes, say, usually allows you to hear about their main concern, which may be brought up at the end. Then you can decide with your patient what can be addressed today and what can't, and what is most important to them. Charts are complete, lab results have been filed or inputted, all exam rooms are stocked, and having translators available if necessary can all really help you to avoid long visits and allow you to maintain a single-length visit appointment system.
How do you make the leap to this new and potentially very different kind of appointment system than the one you've been using? It can't be fully implemented tomorrow. It will probably take at least a few months. As you can imagine, converting to open access is not an easy task. The very first step is to get as much buy-in from every staff member and provider as you can. Without staff buy-in, success will be challenging to achieve. We'll spend a little time talking about some ideas for involving staff in the process as a way to get buy-in.
Within your leadership team, identify a senior-level staff person who is passionate about improving efficiency and patient satisfaction, and who has both a strong commitment to it and the authority to ensure that it gets implemented. Sometimes the reasons for leaders to be unenthusiastic is that they don't have all the information. Data is usually the most powerful information to support the need for change. You may want to report on such things as patient and staff satisfaction or other efficiency indicators.
But no matter how committed top leaders are, the effort will get derailed if the entire staff is not involved in some way and on board. Remember that in order to succeed at making changes, all staff need to see how giving up something like old habits or old procedures, for example, will result in something better: increased access, more satisfied patients, better quality of care, and happier staff. If you can't convince staff that outcomes will be better, don't expect them to endure the pain of change.
So here are some suggestions for reducing resistance to change. Provide all the facts about the reason for changing and give information as early as possible to avoid surprises. Explain the benefits as well as potential risks and why they're worth taking. By being upfront from the beginning, you can prevent rumors, misunderstandings, and resentments. Explain that there will be many opportunities for staff to provide feedback on how it's going. Based on feedback and monitoring, decisions may be adjusted and tweaked and then evaluated again.
Involve staff in planning and implementation. Those who are on the front line often have the greatest insights, and staff takes on a more personal commitment when they know their opinion is valued. Keep in mind that the more complex the problem, the greater chance of failure. So though your goal is to convert to open access, or at least perhaps have more same-day slots available than you do now, consider the advantage of making gradual change rather than everything at once. Consider how the timing of proposed changes may affect other things and plan carefully. Perhaps it's wise to not begin your conversion at a time when many of your providers are on long vacations.
Acknowledge the rough spots. Even a minor change is rarely simple. Admit it and tell how you plan to resolve the rough spots. Once you've gotten everyone on board, the next step is to begin the actual transition to open access. You are likely starting this transition with a very full schedule of patients, and the goal will be to create space in your schedule for patients to begin being seen more immediately. You will need to figure out and commit to how the practice is going to gain the capacity to do that.
It's critical that you develop a plan for reducing the backlog of appointments to free up the provider's schedule in the future. Agree on a target date to not pre-schedule beyond. So for example, if today is January 1st, your target date may be April 1st, and you would begin seeing more patients each day in order to reduce your backlog of patients so that by April 1st, at least 30 to 50% of the schedule is same day or next day. The goal is to carve out more and more time each week to reach this goal. This is a more gradual approach. The other option is to choose a date and just begin open access on that date. This is dealing with patient backlog after the start of open access. You have to be willing to stay late to see all the patients who want to be seen during the first few weeks of implementation until you no longer have a backlog, and it can be challenging if your backlog is large. It can, however, be the fastest route to converting.
For the gradual approach, you must be willing to see more patients each day for about 6 to 8 weeks, and extend clinic or office hours each day until you no longer have backlog. You're already probably doing this informally at times when your schedule has been double booked and you've run behind schedule, but you can count on this occurring regularly until your backlog is gone. Providers can reduce demand by consolidating current appointments with future appointments. Look for upcoming appointments on the schedule and consolidate them into one appointment. For example, someone might come in with a sore throat and also have a future blood pressure check scheduled. Also ask yourself, can I do more with today's visit to make this a richer visit? By having a more established and stronger relationship between patient and provider due to patients being more consistently scheduled with their own provider, it can be easier to cut to the chase, so to speak. This gives you time to address other issues that could have surfaced during another potential future appointment, but now you can address it during this visit. You can also potentially use a higher CPT code for this visit.
Another way to reduce demand is to remove any unnecessary appointments from the provider's schedule. Are all follow-up appointments necessary? Are they clinically necessary or just habit or culture? Create office hours on a provider's normal day off. This may not be a popular decision, but any provider who is willing to make the sacrifice could work during that time, and it would just be temporary. You can also use phone and email to communicate with patients. An office visit isn't always necessary. You can also offer group educational visits so that less time is needed to provide education during the patient's individual visit.
After this transition period, the only patients who should still be on the schedule are patients who need follow-up visits and patients who do not want to be seen on the day they call, which is what we call good backlog and was introduced earlier in the module. The open access model uses single-length appointment types, or alternatively, the goal is to at least minimize the types to 2 different lengths, such as a 15-minute appointment for most appointments and 30 minutes for only longer procedures and physicals. If you wanted a slightly longer appointment time, you could have 20 minutes as your minimum and 40 minutes as your longer appointment. Though appointment lengths vary, keep in mind how long the provider actually needs to spend with the patient. Usually 15 to 20 minutes is fine.
In order to better understand your patient demand, it can be useful to identify the appointments you do schedule with one of the following. Doctor request for follow-up appointments that a provider instructs you to make. Patient request for when a same-day appointment was offered but the patient requested another day. Same day for when a same-day appointment was made. And no match, which means that the patient's needs were not met. In other words, they didn't get in as soon as they wanted to. These are the important indicators to monitor once you've implemented this system.
Using these labels does not mean that you stop identifying the reason for the visit. You do still need to indicate this so that staff can be prepared. Determine a window of days within which patients can make appointments so they don't have to call back for the same day appointments. Experiment with the size of the window, since you may have to consider accommodating patients who want to make an appointment beyond your short window. Be careful, though, to watch for accumulating backlog. Some sites have found that 50% of patients were seen the same day they called, 20% were seen the next day, and the remainder were seen the next 3 days, so one could establish a 5-day window of time to allow patients to make appointments and not have to call back for a same-day appointment. In some instances, if some patients are not happy about not being able to make advanced appointments, we've heard of some sites extending the window up to 15 days, but keeping a sharp eye out for accumulating backlog.
We all know that the best laid plans do not always result in 100% success all of the time, so it's important to develop contingency plans. Demand is not always predictable, and there may be days when your site is overwhelmed with patients who want to be seen the same day. What if a provider had to leave the office unexpectedly? What do you do? Who can help the provider if demand is too great? Perhaps there is a nurse or a mid-level provider or colleague available that can step in, bearing in mind that you want to maintain continuity of care as much as possible, but there will be some exceptions. To develop a contingency plan, first we want to plan ahead. Is the provider's time being used most efficiently? Consider what we talked about when we were discussing minimizing long visits and waits. Are the rooms stocked? Can a medical assistant provide the education, etc.? Are there ways you can spread out increased demand during predictable times? For example, offering flu shots a couple of months early before flu season starts might help spread out the demand.
In order for open access to be successful, providers must have the appropriate panel size, which means the appropriate number of patients so that demand for appointments is matched with appointment supply. Calculating panel size also helps you determine if you can meet revenue requirements to cover expenses and salary expectations.
Panel size will depend on a number of things. How often the provider is in the office, the type of patients in terms of care needed and level of risk associated with their care, the provider's style. Do you have some providers who insist they can only see 2 patients per hour because of their communication style? And the provider's scope of practice. How much will providers be managing themselves versus referring out to specialists?
As Murray, Davies, and Bouchon say in their excellent article on panel size, if panels are too big, providers create overwork. They can't get the work done. Over time, they need consistent overtime support, and over there, they send the work away. If the panel is too small, providers will not generate enough revenue to cover expenses. Some providers feel that they just have to say yes, yes, yes to all potential patients, whether it's to please the patients or grow the practice. But what they need to realize is that ultimately their practice will suffer and productivity will decrease when panel size is too large and they are not available to meet the demand. Here's what can happen.
Because the provider has more patients than he or she can accommodate, wait time to get in for an appointment increases. There is an increased number of phone calls due to the increase in patients and therefore more time spent on the phone to figure out when to schedule them, and more time spent on triage. There are more complaints, an increase in no-shows, canceled and rescheduled appointments, less continuity of care since patients will be willing to see anyone in the practice just to get an appointment, which worsens patient outcomes and satisfaction and also increases the return visit rate and visit length, which in turn lowers productivity.
This article, Panel Size, How Many Patients Can One Doctor Manage, includes an excellent explanation of how to determine your current panel size and how to determine the ideal panel size. It includes an Excel worksheet that you can download for free, and it will perform a number of the calculations for you. This is a picture of what it looks like. As you can see, it walks you through calculating the practices panel, and then what the target panel should be for each provider, essentially dividing the total number of unique patients in the practice by the number of FTE providers. In this case, the actual panel size per provider is 2,000. If you don't know your actual size, you can use the 4-cut method, which is also described in this article.
To do the 4-cut method, you assign patients to providers based on the following criteria. Patients who have seen only one provider for all visits are assigned to that provider. Patients who have seen more than one provider are assigned to the provider that they've seen the most often. The remaining patients who have seen multiple providers the same number of times are assigned to the provider who performed their most recent physical or health check. The remaining patients who have seen multiple providers the same number of times but have not had an annual exam are assigned to the provider they last saw. This method will not necessarily be 100% accurate, as some patients may end up choosing a different provider, but it's a good place to start. Panel assignments can be fine-tuned by taking every opportunity to ask patients their choice of provider.
In this example, the actual panel size per provider is 2,000 patients. The difference between the actual panel and the target panel is 400 patients because this provider actually works 80% time, so the target panel is multiplied by 80% before subtracting from the actual panel size. This provider is seeing 400 more patients than his or her share, given what the practice is seeing. The next set of calculations is determining the ideal panel, given the number of visits per patient per year, the number of visits to a given provider per day, and the number of days that provider works. You can see in this example that because this provider can see 24 patients each day and works 240 days per year, that the ideal panel size is 1,806 patients. Don't forget that you have to divide by the number of visits per patient. The difference between the actual number of patients, which was 2,000, and the ideal number of patients for this provider is 194. So this provider is seeing 194 more patients than she should, given her availability. We highly recommend that you take the time to do these calculations for your own practice. These last calculations that we just did will show you if you will be able to meet the demand given the number of patients you have and the number of hours you work, something very important to know in order to successfully use open access. However, it will not show you if you're meeting the financial goals of your organization.
Sherry Anderson DeLeo, in her book The Perfect Practice for an Efficient Physician, provides a relatively simple method for determining if it's possible to meet your financial needs with your current provider and patient scheduling, number of visits, and reimbursement rates. She has you think about your clinic's total expenses, your desired salaries, the net revenue needed based on your expenses and desired salaries, the average net revenue per visit, the average number of minutes per visit, and the number of visits needed to meet the net revenue requirements. But then you have to consider your estimated no-show rates, and based on that rate, the number of visits you need to schedule. Next, you need to figure out how much time you need to spend in the clinic in order to meet salary expectations. So you need to know the number of scheduled hours you need per year. If you know the number of weeks a provider spends in the clinic per year, then you can figure out the average number of hours needed per week.
So let's look at this example of this individual provider. Dr. X's total expenses equals $200,000 and her desired salary is $150,000. Therefore, the net revenue needed is $350,000. The average net revenue per visit, let's say, is $100, and she spends about 20 minutes per visit and averages 3 visits per hour. The number of visits needed is calculated by dividing $100 into $350,000, and you come up with 3,500 visits. However, there is a 10% no-show rate, so you actually need to schedule 3,850 visits, 350 extra visits. If you divide the number of visits by the number of visits she sees in an hour, so 3,850 visits by 3 visits, you get 1,283 hours needed per year. So if Dr. X works 45 weeks a year in clinic, you would divide 1,283 hours by 45 weeks, and you end up with Dr. X needing to work 28.5 hours per week. Notice, however, that the outcome of 28.5 hours per week that Dr. X needs to work is all based on a net revenue of $100 per visit. Depending on your capitation rate and if you receive a flat rate per patient per year, or if it's a per visit rate, these variables will influence your calculations. The number of patients Dr. X needs to have in her panel is also influenced by whether or not she needs to see more different patients or not in order to get a specific rate per visit.
We talked panel size from the perspective of the appointment system and revenue, but there are more reasons why establishing a panel for each provider and assigning patients to individual physicians at the site is important. The benefits include that patients are more satisfied. They really want the opportunity to choose a primary care provider, and they want a positive relationship with that provider. When you establish a panel, it links each patient with a provider with whom they have a healthcare relationship. It defines the workload. Establishing a panel helps ensure a balance of patients among providers. Other benefits are, it's a predictor of patient demand, and we don't mean just appointments, but for the amount of paperwork and emails that are generated, the number of lab tests and procedures and hospitalizations. Understanding the panel helps a clinic anticipate that demand. It reveals provider performance issues. Knowing each provider's panel size allows you to compare demand or number of visits between providers who have the same panel size. If there are differences, you can decide if those differences are justifiable or if something needs to change. It helps improve outcomes. When providers identify which patients are in their panel, they can more easily make a commitment to provide continuity of care, meaning taking care of their own patients for all their visits, which results in improved clinical outcomes, decreased cost, and increased revenue per visit.
Other things you need to consider as you plan and implement open access is that this is really a change in healthcare culture in some ways. Patients are accustomed to planning ahead, expecting to wait, and sometimes seeing many different providers within the clinic. It will be important to communicate the new process to your patients way in advance, perhaps 2 to 3 months prior to beginning the transition. They do not need to know all of the details in advance about what may occur during the transition, but they should know that you will be converting to a new appointment system model that will allow them to be seen the same or next day, and that the goal will be to schedule them with their primary provider as much as possible, so that their provider can establish a more familiar and stronger relationship. The clinic will be quite busy during this transition, but the change will result in much more efficient services.
Changing to a different kind of appointment system can sometimes cause other systems issues to surface. For example, if your practice is used to preparing charts, if you haven't converted to electronic medical records yet, or confirming if lab results have been filed or entered the day before the appointment, what will you need to do to ensure that records are prepared for appointments that are made the same day, without last-minute chaos? Monitor how the new schedule is affecting your other systems and then modify your processes as needed. We've talked a lot about specific appointment systems and characteristics with a focus on open access, but now we'd like to give you some best practices, advice, tips and tricks, suggestions, or whatever you'd like to call it, that have proven to be helpful regardless of whether you move to a strict open access model or not.
Every site should have a phone scheduling protocol. It should include at a minimum the following information: how to register new patients over the phone. This is ideal because it can prevent long delays when the patient comes in. How many appointment slots are staff allowed to use for one patient? The importance of making every attempt to schedule patients with their primary physician, as well as the exceptions. The urgency of the visit may outweigh the importance of continuity of care at times. Consider when your phone lines will be open. If you want to have some early morning slots available on the same day, your phone staff must be available to schedule patients before the first opening. Alternatively, all pre-scheduled appointments could take up the early morning slots so that the same days don't begin before 10 o'clock or so.
The phone or scheduling protocol should have what questions you need to ask patients and what your patients need to know in advance before coming in. Ask for the purpose of the visit, but remember, with open access, it's less necessary to obtain a lot of detail since all appointment slots are the same length.
Do remind patients to bring in their copay or any balance due, as well as their insurance card. If patients have access to a fax, you can ask them to fax in a copy of their card so that staff can verify eligibility before the visit. Remind patients to bring in all current medications so they can be documented, and any refills that are needed can be prepared for the provider to sign off on. Doing so can help eliminate a future phone call from that patient requesting a refill, and it's a more efficient way for the provider to learn what medications the patient is taking.
Ask parents to bring in their child's immunization records if appropriate. Be sure to determine if this is an ER or hospitalization follow-up, and if so, make sure you obtain the hospital name and order the discharge notes in time for the visit if possible. If your patient does not want to be seen that day or the next day, don't make them call back. Just schedule them on their requested day within your agreed-upon window for appointments. This is better customer service and also prevents the phone staff from receiving unnecessary repeat phone calls.
Something else to consider is that you could give your patients access to the provider's schedules. You could do so by posting them on your website or making it available through your phone system or as a printed handout if the schedules don't change often. That way, patients are clear about which days to call or whether or not they'll have to see a different provider. Consider the benefits of establishing appointment-making rules for provider leave. The last thing you want is for the provider to return to a full schedule, which will then be the beginning of the return to a traditional model with long waits for patients to be seen. Sites have been able to maintain open access by blocking the provider's schedule during the week he or she returns. Then, 3 days before he or she returns, half of the appointment slots are opened on the first day back in clinic. Then 2 days prior to his or her return, half of the slots are opened on the second day back. And then finally, 1 day before the provider returns, all of the slots are open as usual.
We suggest that you don't have separate appointment pages or screens for each provider. It's important to be able to see everyone at the same time so you know how the combined schedules are going to impact the front desk and the rest of the staffing. Because demand does fluctuate, all staff should have the ability to schedule patients, but only if all staff are knowledgeable about appointment-making protocols and agree to follow them.
The Perfect Practice for an Efficient Physician by Sherry Anderson Delio suggests that there be 1 front office staff and 2 back office medical assistants for every full-time provider, with front office obviously managing intake, 1 back office assistant assisting with processes such as rooming and procedures, and the other managing paperwork and follow-up. Cross-train staff so no one's waiting for someone else to do their job. While ideally you want staff to work at the top of their skill level, cross-training can ensure that work and patients continue to flow regardless of how busy any one particular staff person may be.
How does one know if this new schedule is working for them and their patients? If you're able to schedule the majority of your patients on the same or next day, that's an excellent indicator. There are other things that should be looked at as well. First of all, before practices begin, they need to really determine a baseline for performance and then check again after open access has been implemented for a period of time. For example, check the percentage of appointment slots that are open at the beginning of the day and then see if that changes over time. Other indicators to measure would be what's provider productivity? What are your no-show rates and cancellation rates? Monitoring these indicators on a daily basis in the beginning will give you a good idea of whether or not you're moving in the right directions, or if changes still need to be made. Once you have settled into open access, it will be important to continue to monitor indicators at least once a month. We hope that we have helped to expand your knowledge about open access and have at least given you some ideas or strategies to consider as you work towards improving your current system. There is no reason to feel stuck with the challenges you might be experiencing, and every reason to work towards the changes that will improve your patient's experience as well as your own staff's experience.
This concludes this session. Thanks for participating. For other training, please check these websites.